lights, and everybody goes to sleep. Turn off the lights, and then, put on the PowerPoint, and then everybody goes to sleep.
No, the next, yeah. The one to the,
This one?
The second one.
It was.
yes.
Okay. How about you guys in the front?
No.
Right?
That's good.
That's good.
Yeah, perfect.
Right. So we're talking about labor delivery again. It's going to be something repetitive for people who had Carol Jasco's lab. People in my lab will have it this week. Okay. So let's take a look at this.
Wait, so that's not the same?
This PowerPoint was actually done by a nurse, actually, who wants her going to Valley. She is a nurse at Valley Hospital named Grace. And she was doing the master's degree program here. She's a Robert Wood Johnson scholar. So her master's degree was paid for by a grant. And they gave her a computer, and all her textbooks were covered by that. And I recommended her to the program because she's such an excellent nurse in labor and delivery. She looks like she's about 25, 24, she's very young, okay? But she has a real passion for labor and delivery and holistic nursing, okay? And when she was a student, she had to do 2 lectures in my class, because her interest is, OB. And this is one of the lectures that she had done. I thought it's nice to see. It's pretty and it's colorful compared to my boring looking thing. So hopefully you'll enjoy it like I did. Alright, so what influenced the onset of labor? Okay. There's different theories out there, and no one really knows 100% for sure what really it is. Okay. They think that the uterus, once it gets stretched out beyond its normal amount of stretching out, will produce hormones to cause the person to start going into labor. That's probably part of that reason is if a woman's carrying twins or triplets, her uterus gets bigger than the normal person who's pregnant. And people who have twins or triplets or quadruplets go into preterm labor more frequently than people who are only carrying one baby. Okay? So that means the uterus will stretch out that much more and further along as, or earlier in the pregnancy than a woman who goes to 40 weeks. Okay? Okay. Another thought is progesterone. Remember we talked about the hormones in the menstrual cycle, that the last part of the menstrual cycle, progesterone is the big hormone, okay? And progesterone is progestation. It keeps the pregnancy in place, keeps the uterus quiet, not contracting, so they feel as though there might be some kind of withdrawal of the progesterone from the placenta, and because it keeps the uterus nice and calm, if you take away the progesterone, the woman will start to contract. Okay. Other theories they have here increase oxytocin sensitivity. The brain, one part of the brain does produce oxytocin. It's not just it's endogenous in the brain. Or increased release of prostaglandins. Prostaglandins are not really hormones, but they say it's a sort of like a hormone. And prostaglandins causes like menstrual cramps or cramping. Okay, so they're thinking that maybe that could be also a reason, but no one knows 100% for sure why a woman does go into labor. Some of the early signs of that the woman is going to go into labor, maybe the day before or the day of labor, she'll have some certain symptoms that will go along, and all of a sudden, the next day or that afternoon she goes into labor. Lightning is a term that you'll hear, it's going to be on the test, and it means that the woman drops. In other words, her uterus drops. Okay, so sometimes you'll see that the woman, the fundus of the uterus is up to here on her, right by her chest, and when the uterus drops, she can breathe better, because a lot of times it's obstructing her diaphragm when the baby's up so high. And then when the baby drops or lightning occurs, the baby will go lower, but what will happen with that is she'll have to urinate a lot, because now the baby's sitting on the bladder. So lightning refers to the uterus dropping a little bit. Usually it could be anywhere from 36 weeks She can have that sign, or it could be when she goes into labor. So it really just depends. Braxton Hicks contractions, those are what they call false labor contractions. It's like a balling up feeling sensation in the uterus, and that is, there might be a little bit more frequency of those kind of contractions, but the thing about it is, the only way you know that a person truly is in labor is if she's dilating and the cervix is effacing. Okay, so when she starts to dilate the cervix and the cervix starts to thin out, then in that case, she's truly in labor. Okay. And then increased energy level, like a nesting feeling. Sometimes it's like referred to as the woman starts, cleaning all the baby clothes, washing and putting in drawers, cleaning her house, like they call it nesting kind of syndrome. Cervical changes, the cervix will start to get softer. Some dilation may occur. A bloody show is when the woman is pregnant. There is a honeycomb kind of structure that blocks the cervix and sort of protects that no bacteria gets into the cervix. And what happens is when she starts to dilate a little bit, this area of the cervix is sort of like being blocked. It's like really referred to as a mucus plug, okay? And when she starts to dilate, the mucus plug starts to come apart, and you'll see something with blood and mucus, okay? So that's what's called bloody show. And then a spontaneous rupture of membranes. Okay. Some of the key facts to remember. When you think about the woman who calls the office, or she calls the ER, or she calls her doctor or the clinic, they want to know if she's truly having labor, or she not really. She might have those Braxton Hicks false labor contractions. How would you know that? Okay. So, true labor, your contractions are at a regular interval, meaning you're having your contractions like every 15 minutes. 15 minutes, and maybe go to 10 minutes apart. So they are like a pattern developing. False labor, they're irregular. The contractions might be, I feel one now, I feel one an hour from now, I feel one half hour. So it's not a pattern established. The interval between contractions will gradually shorten, meaning that, as I said, you go from every 15 minutes, and then you go to every 10 minutes, and then you go to every 8 minutes, so the time between the contractions gets closer and closer together. False labor, there's no change, there's no pattern again. Contractions increase in duration and intensity as labor progresses. With false labor, there's no change. Okay. Discomfort begins in the back and radiates around to the abdomen. This is usually what women feel when they're in labor. It's almost like a belt kind of feeling that goes from the back all the way to the abdomen. In false labor, it's just usually the abdomen. Okay. Intensity usually increases with walking when you're in true labor. Walking has no effect or lessens contraction in false labor. The big thing in true labor, again, is cervical dilation and effacement of the cervix, thinning out of the cervix. In false labor, there's no change. And then in true labor, contractions do not decrease when a woman takes a warm bath, or she rests or lays down and drinks some fluid. Okay, so she will keep contracting even if she hydrates herself and relaxes. In false labor, rest and warm baths will lessen the contractions. Okay. So those are some of the important issues when it comes to true versus false labor. Okay. True labor is defined by progressive cervical change and then fetal descent. So again, as I said, the cervix will be thinning out and dilating. Okay, so that is a big factor with true labor. Contractions are regular, frequent, frequency, and intensity, and duration will increase, progress. Labor pain usually begins, as I said, in the back, and radiates to the front. Ambulatory, if you walk and it will increase the pain, and rest will not decrease it. So that's sort of repeating what I just said. And then this is, again, what we talked about in that the second slide there. Okay. Critical factors affecting labor and delivery, the 5 Ps. So this will determine if the woman is going to be able to have a delivery vaginally, okay? There's 5 different factors for that. There's a passageway, which is actually, if you think about it, the pelvic structure, the bones in the pelvic structure of the woman. Also her cervical canal, okay, where the baby comes out. So those will make a difference as to if the baby can be delivered vaginally or C-section, okay? The passenger being the baby, the power are the contractions, the position of the baby, what position the baby's in, and then the psychological and physiological response. If a woman is very uptight or stressed, that will cause her muscles to get, tightened. So you might feel longer labor if she's a little bit more stressed. Okay. Okay. So other factors affecting the labor process here. Now this looks like a woman who has they call it a doula. Has anybody heard of a doula before? Doula. Okay. So doula is somebody who will assist somebody in labor. They can be a lay person, or they can be somebody who might be a labor and delivery room nurse, and she goes outside from her her labor and delivery area, and then will help somebody in labor. So they're really sort of like a coach for the woman in labor, and they're also a calming factor for the person in labor. And again, as I said, they're trained. They have courses on how to become a doula, but they don't have to be RNs. Or in the medical field, okay, just somebody, a lay person, or it can be an RN, it doesn't matter, but it's a course that they have, I believe they still have it at Valley, they have a course like that, where the person learns how to deal with the person in labor in a calming way, okay, and usually with a doula, they're really into helping the woman deliver the baby without any kind of pain medication or anesthesia, okay. So philosophy, low tech, high touch. So you can see that with a doula or even a midwife. I mean, be able to see a delivery either with a midwife or somebody who's a doula. Even the nurses in labor and delivery, I can tell you at Valley Hospital, they're all trained in spirituality and touch. Very holistic there. They all had to take some course someplace in Malwa, and to learn how to use different oils on the patient to relax her, using different points on her hand and massaging her hand, massaging her back. And so they try to keep it, low tech and high touch. Okay. Also, partners support caregiver. If they have that. Patience, which is natural timing. A lot of times what happens is if the doctor's really involved with it, he'll up the Pitocin. Pitocin makes him contract more, just to have the woman deliver, or they might say things like, that's it, I don't have any more time, you've been in labor for 24 hours now, and we're just going to have a C-section. So again, the woman's at the mercy of whoever her care provider is, because after you're in labor for 24 hours, you're exhausted, and you just want to have the baby. So you might be convinced that you want to have a C-section at this point because you just had it, you're just tired and haven't eaten and all that. Patient preparation, childbirth knowledge base. Again, they have childbirth classes that you'll attend one class. Some people do reading. They actually, at Valley, they do have an online childbirth class that the people could take in their own home. It costs a couple $100 though. But, if they don't have the time, some people just work or they have other kids or something where they can't go to a childbirth class. So, I think the nice thing about childbirth class, you'll see when you go, okay, people get to know each other. My sister, how old is she now? 53, is still friends with the people from her first child's childbirth class. Like they're all going through it together, and they all live around the same area, and she lives in Ridgewood, and she's still friends with these people from how old is Richard? 27 years ago, 28 years ago, right? So it's sort of like a bonding for the parents to compare notes on what they're going through, you know? We even had situations where people in the same childbirth class were in labor at the same time. It's sort of funny, you know? Or we actually had two sisters who went into labor the same day, and both laboring, you know? So it's sort of interesting to see that too. All right, pain control or comfort measures is also a factor. Again, it really depends on the mindset of the patient. As I said, I can talk from Valerie's point of view. They have this person named Heidi. She is involved with a holistic care, plan for the birth. So what she does is she makes it be known to all the different doctors' offices that she's available for anybody who is interested in having childbirth without any pain measures, pain medications or anything like that. So she meets with the people, and what will happen is she has them fill out a questionnaire of what they want and don't want in labor, and then she puts it on their file so that when they come into labor, they have all that information knowing that she wants a natural birth. But again, if it's your first child and you go in with that whole idea of a first birth, and you're 5-10 hours into labor, you might actually change your mind, and you're allowed to change your mind. That you might want an epidural or something for pain, because you don't know what it's like when you're signing something and never had a baby before. Yeah.
I know that Valley Hospital has a very very based on holistic.
Yes.
Okay. What happens if the person the mother who's pregnant, is in labor and not anywhere around?
I'm sorry. What is giving what?
My question is, if the patient's like mentally prepared to do this
Right.
natural birth, but they end up in a different hospital, do they usually accommodate
They probably would. I would think they would try to. I would hope they try to. I mean, she would make it clear that right off the bat that I really want a natural birth. It's funny because Valley is into that holistic and the family being involved and all that. It would be hard to maybe go to someplace else who don't have that mentality. She could just tell the person she's not interested in it. They can respect her wishes, but she may not have a nurse who will do. When Grace was here, she was showing how you do. They call it pole dancing. When you have a baby, you're trying to get the person to sort of stand up. It's not gravity, But again, if the nurse is not doing this kind of stuff, the oils and soothing and all that kind of stuff, then they can't do it. The only thing that if the woman wishes not to have anything for pain, then she doesn't get anything for pain. Yeah. Yes.
Like, I know when I went in for my birth,
Yeah.
I wanted an all natural birth,
Right.
but the hospital I
You're
went
too young. Look at you, so young to have a baby. I mean, you know what? I know I'm getting old. Is when I think people are so young. You know Susan at the desk, at the front desk. When you come in, you'll never guess her age. I'm totally shocked. She told me last week. Do you know what I'm talking about? Susan?
Yeah.
Think in her 40s.
Oh, wow.
She's not brandy. She's so brandy.
I almost fell down last week when she told me that. I thought she was like 30 years old.
I just fell.
She looks young. She looks so.
She's so brand.
I was shocked.
She's so good
Sorry.
looking. She's
Don't
beautiful.
tell Susan I told you that.
It's her nursing home.
That's why I thought it was birthday was recently. I said, what are you, 29, 30? She's like, I'm like, tell me her age. I was like, what? She's been here. But anyway, sorry, go back.
But the hospital that I went to, they weren't very accepting of that. They kept pushing for that. So I had a doula too.
Oh, you did?
So I had that support because
Yes.
the nurses there, they just like get your epidural now, and they kept pushing for it.
Yeah.
Until it came time. Well, I didn't even know I was ready to give birth, and I changed my mind.
Yeah.
I wanted it, and then it was too late.
Oh, yeah.
So I just ended up having a natural birth. But like, they weren't very therapeutic about it. They weren't trying to accommodate me.
Yeah.
They were very pushing towards it.
Really? Yeah. It really does depend. You're going to Hackensack?
Sorry?
You're going to Hackensack?
Yeah.
All right, I don't know how they do things, to be honest with you, but the nice thing about it is, I don't know, I really don't, because I went there once semester. I like Valley, I live close to Valley.
Hackensack is like
But I like that, like, just because of the philosophy. But see how it goes at Hackensack. The nice thing about it is, a couple of the nurses there have done their master's, degree, actually probably at Ramapo, but they come here to have like a, to be with the professor, like that, like Carol Jasko had a couple of people who were, L&D nurses, and, she was mentoring them. So the nurses there all know Carol, which is a plus.
Yeah.
And so you'll be able to, really observe and see how they are. And the same thing with Valley.
Me?
There's always
Just for the
a
old
couple of
book.
nurses who don't want anything to do with holistic.
Do you have the old book?
Although they're all trained,
And the old book
and then
for-
there's it seems like the younger
You do?
ones,
She was handing it out
the
in the
younger
beginning.
ones are really into
Ask her.
trying to have a real
After
nice
class.
natural delivery. But, again, it also depends on the philosophy of the doctor too. That makes a difference, So, yeah.
Just one more question. I
Yeah.
know that with regards to pain medication, the earlier you asked for it, the more efficient it is. Right? Is that?
Not necessarily. I mean, for an epidural, which is a local, it's basically almost like a spinal, but it's not a spinal. It's outside the spine. They usually say that they want the labor to be established before they, meaning like shoot out at least 3 or 4 centimeters dilated before they give her the epidural, because sometimes the epidural will will slow down the labor. Where so if it's given too early, the labor might slow down and not be sufficient. So it's not always the case, with pain medication. And again, you have the right to change your mind. That's the thing, you can't, as much as you want to do all the things, you don't know what it's like in labor until you are in labor, and you don't realize, I'll say the word discomfort, but it's damn pain. I'll be nice, but I'm telling you, it is painful. It's almost worse than a root canal without being numb. Jesus. Okay. So the passageway, as I said before, it's really the bone structure, the bony pelvis that the fetus has to maneuver its way through before it can come out vaginally. Okay, so there's different structures. Women have different structures of their pelvic, bony pelvic area. Okay, the one that is the most favorable is called the gynecoid. Okay, because as you can see, it's a nice round structure, and the baby's able to get through it. Okay, easier. I'm just trying to show you the shape of this. Android over here is a little bit more difficult. You see at the end here, it's a little bit narrowed. Okay, and then over here, the anthropod here is not usually favorable for a vaginal delivery, and neither is this one here. Are not favorable. So really, the first two are the most favorable for a baby to be able to descend. And again, you're looking at this is where the ischial spines are in the bony structure here. Okay, and you see look at how narrow it is here. It's narrow here. So that's what we're looking at. Passageway for the pelvis. There's the false pelvis area, and that's the upper part of the pelvis. Okay. Pretty much, this is the ischial spine. These little things sticking out here, ischial spine. So the false pelvis is basically above that. Okay. The true pelvis is below that. Okay. So false pelvis means any baby can get through that. Okay. The true pelvis is not all babies can get through here, okay, and down. So that's the division of it. The true pelvis has the pelvic outlet, meaning when the baby is going to come out. Okay. You see here the baby is descending. Ischial spine is there. So this is where the baby's in the false pelvis, because look at all the room. Any baby can get through there. It's just when it gets a narrow area that if the baby's head's too big, the shoulders are too big, that the baby can't descend. Okay, so we also have the passageway, the soft tissue. Okay, The cervix effaces and dilates to allow the presenting part to descend into the vagina, okay? So the cervix goes from being totally closed, okay, like this one here. This is totally closed, okay? And it goes to, makes it to 10 centimeters, hopefully. 10 centimeters is the goal for the baby to be able to come out vaginally. So it progresses to 10 centimeters. The other thing, when the word effacement or effaces, the cervix here goes from a thick structure to something as thin as a piece of paper, okay? And that's effacement. That, they usually will use for effacement percentage. So they might say she's 5 centimeters dilated, 50% effaced, okay? Or they'll say she's 75% effaced. The goal is 100% effaced, right? Because you want 100% effaced and you want it to be also 10 centimeters dilated. Okay. The pelvic floor muscles help the fetus rotate anteriorly as it passes through the birth canal, and the vagina will expand to accommodate the fetal birth. Okay, so you see these are the cervical changes in labor. As I said, we have progressive thinning of the cervix, and then you have dilation of the cervix, cervical os. So if you take a look here, this is when there's no, see how thick it is, and it's closed. So that's the cervical canal here, okay? And what you're seeing here is the cervix being very thick, and the external os is not open, okay? When we go down here, you can see how it's thinning out, like 50% thinned out compared to here, okay? And then the external os is dilating. And this one is that she's 100% effaced, and again, look at where the external os is here compared to here. And you'll see that she's 100% effaced and she is 10 centimeters dilated. Okay. So it is progressive. Okay. The other thing the baby has to do is, we have to know how big the baby's skull is. We have to know a little bit about the baby as far as position goes, the way the baby is lying in the belly. So this way we can get an idea if the baby is going to be able to come out vaginally, okay? The fetal skull is the largest and least compressive structure, okay? It does have those suture lines in the baby's skull, like there's like the little openings. They have the fontanelles, and they have the anterior fontanelle and posterior fontanelle, like the little openings in their head with their bone. And that's allowing for this maneuvering out. Sometimes the babies will come out and their heads will be a little bit like cone heads, or you'll feel the overriding sutures. Sometimes they just get overrided because they needed to mold to get out correctly. So you'll see that sometimes with the baby. Okay. So sutures allow for overlapping and changes in shape, molding, and helps identify position of the fetal head. So you can see here. See, this is the baby's suture lines over here, over there. So that's the back of the baby's head. Okay. See here, you can see this too. The front of the head. And again, you're just sort of looking, you're feeling. You can feel like with this baby here. That's the anterior fontanelle. It's really like shaped like a diamond. Okay. Where the posterior fontanelle over here, it's shaped like a triangle. Okay. So you can tell which position the baby's head is in before it delivers. The diameter of the baby is the occipital frontal or occipital mental. So what they're trying to do is see when they are, feeling what the baby's head is. They're trying to get an idea of what position the baby's head is in and how hard it's going to be for the baby's head to come out. And here's another picture of this. This is showing what the occipital mental. Okay, so occipital is back here, mental is the chin. Okay, so you have to, you sort of get an idea of that diameter. But I would never ask one on the test what's the average or anything like that as far as these diameters go. Again, you're going to see this is the baby's head. This is the frontal bone here. Okay, this is the anterior fontanelle, shaped like a diamond. and you follow the sagittal suture line, and you can feel in the back by the occipital bone, the posterior one, which is shaped like a triangle. So when they test the mom, when she goes into labor, and when she goes into the labor room, even before they decide she truly is in labor, okay, what they'll do is usually the nurse or the physician or midwife will come in and check her pelvis. And what they're looking for is how far she is dilated, okay? They want to know how much effacement has occurred, and they want to know the station of the baby, okay? So these are the things that they are feeling for when the woman is in labor. And if you look here, this is what we call fetal station, okay? And this area here, the ischial spine, see where they're located, the little pointy things here, okay? Around that area is called the zero station. When the baby's head reaches zero station, it's referred to as engaged. The head is engaged once it hits that zero station by the ischial spines, okay? And the thing about that is when the head's engaged, usually the head doesn't go back up, all right? So unless they do a C-section for some reason, but the head, once it's engaged, it will continue going down. Hopefully everyone sees the good pelvis there. But so you see, this baby here is now considered at the -4 station. All right. So every centimeter that the baby is above the ischial spines is considered a minus. And I always say, if you think about it, it's a minus for the woman, it's a minus for the baby, because the baby is high up still, and the baby has to descend and get all the way down to here. So it's a negative for the mother, it's a negative for the baby, and it's done a negative. So 1 centimeter above the ischial spine is -1. 1 centimeter above, 2 centimeters above is -2, and from there you can see that. Once the baby hits this zero station, the head's engaged by those ischial spines, and every centimeter coming after the baby's head's engaged is plus, because it means that the baby is really good for the baby and the mom, that the baby's going to start descending. So again, it's 1 centimeter below the ischial spine is considered +1 station, okay? Then 2 centimeters below is +2. The goal is +4, and then the baby will start to come out, okay? Everybody get that? Okay, so we talk about the different lies of the baby. You want to know if the baby is, which way the baby's lying, basically. Okay, so you can see here that this is a longitudinal lie, meaning that the baby is, it can even be the butt down here and the head up here, but longitudinal is like a straight line, okay? This is a transverse lie. See how this baby is? This baby's not going to come out vaginally. You can see why. The baby cannot descend because it's laying across. So transverse lie is not a good thing. You're not going to be able to deliver that baby vaginally if the baby is like that. It's easier to deliver a baby in longitudinal lie, okay? The attitude we will look at with the baby, the presenting part, and the presentation, okay? And here we have fetal presentation, okay? Here you can see this. This is a face presentation. See how the face, I don't know if you see, that's the nose, the eyes, the mouth. Again, look at the diameter of the head. This is not really great for, it's going to be a hard childbirth, let's just put it that way, okay? So presentation is either going to be cephalic, meaning head, right? Or it's going to be breech, meaning that the baby's going to come out either, feet first or tush first, okay? So vertex is really what you want, okay? So cephalic vertex, we have this vertex here, is the best position for the baby, because that means, see how the baby's head is folded, they want the baby to be flexed, so the baby's head is folded down against its chest, so the smallest diameter of the baby's head is going to be coming out vaginally, okay? So you want, that is the goal, really, I mean, if you get it, this is a good goal to have, that the baby, everything is flexed, the legs, the arms are flexed, the baby's head is flexed against its chest, so that's a vertex presentation. Military usually is, I don't see it here, military is that the baby's totally straight, with no flexion, okay? The baby is just, like a military, straight, okay? The face presentation here, and the brow presentation, see how the brow is coming out first here. Okay. Now this baby here is a shoulder presentation, and again, that might be a C-section, okay? Because look at the baby's head, and the shoulder is going to present, and that is not optimum. Look at how big that area is that's trying to come out. Okay. Then we have the breech. Again, you see the breech baby. This baby is flexed. Okay. This is referred to as a complete breech because the baby's all flexed, just like the vertex. See how this one's all flexed and the head's flexed, but the head is coming out first. The vertex is coming out first. This baby is a complete breech because it's completely opposite of what you want. See, everything is flexed, but its tush is the presenting part. Okay. Then you have a frank breech, which we don't. There's no picture here. A frank breech is when the baby's legs are straight up in the air. I mean, its heels are touching its head. All right. This deflection is in the hips. The hips are flexed, but the baby's legs are like this in the air. Okay. And that's a frank breech. And then a footling breech could be 1 or 2 feet coming out. Okay. And that is that the presenting part would be the foot or both feet. Okay. Transverse is that Y that we had before where the baby's just totally going from one side of the mom's abdomen to the other side. Okay. And then the presenting part. What is coming out first? Presenting part means what are you feeling when you go do the vaginal exam? What is presenting that's going to present to the, coming out the vaginal canal first. So the presenting part could be the chin, okay, coming out. This is the baby's forehead. This is the ragna is the posterior fontanelle. Vertex is the one you want. The baby is totally flexed. Okay, that's the head coming out. It could be also if you're feeling the posterior fontanelle of the baby. And occiput is also that you're feeling the back of the baby's head. So those are some of the things to look for. Okay. So here we have a cephalic presentation. Again, you can see how the babies are lying. Right, this baby here is in a nice position because it's nicely flexed. Okay, and what you feel in the cervical area here, when the baby looks like that, you feel the cervix, you'll feel the posterior fontanelle. You might feel the anterior fontanelle a little bit, but you feel the posterior a little bit more. Okay, with this baby, you can see that the head is turned to the mom's back. Right, so you'll be feeling. What you're going to feel is the anterior a little bit more, and then the posterior right there. Breech presentation, again, what they do with the baby, complete breech is the one that's nicely, folded up like this. Actually, the head should be down a little bit more. This is a frank breech. You see this? How the hips are flexed, but the feet are going all the way up. That's a frank breech there. And then this one here is a footling. See how the foot is coming out? Okay. So the procedure, and you see here with the baby here, look at this little baby. I was saying this to my students the other day in lab, that when the baby comes out, that might have been like a footling breech like this. It's been like this for like 9 months or 8 months, right? It comes out with its legs all the way up in the air. So you always know the baby in the newborn nursery that was a breech baby, particularly if I breech. Every time you put the legs down, they fly back up because they're used to being in that position for in utero. Okay? Eventually it'll come down. These babies are at higher risk for hip dysplasia because look at how they, look how the position is. That the head of the femur and the acetabulum may not be totally in contact with each other. There's something that they call, I'll just briefly bring this up because it's not really in the chapter. What they can do with a baby that's breech, see this baby breech, and it's going to be push coming out first. So what they can do is something called an external version. And they usually will do that around 38 weeks gestation on the woman's abdomen. What they'll try to do is turn the baby around. Now again, this is, what they're trying to show here is that you're actually doing it on the mom's tummy, not internally. Right? You're trying to turn the baby around. And they have, sometimes there's success. I don't know the statistics on it, you know. So they're trying to take the baby, turn the baby around, and they wait until about 38 weeks because she is then considered term, okay? If they did it beforehand, she would be preterm, and there's a possibility her membranes might rupture when they turn the baby, or that, you know, she might go into labor, yeah.
I have a question, with the baby that has his foot sticking out, like how do you deliver that child?
Usually when a baby's like that, you would do, depends on how far along you are. I have seen footling breeches, usually babies that are like very premature, because there's a lot of room for them. So depending on the gestational age, you know, they might, if the baby's like 26 weeks, it's small, they might be able to get the baby out vaginally. Or they would do a C-section, you know, and just get the baby, lift the baby up and out. The passenger, okay. These are field position terminology and abbreviations. And again, this will be on your test. And I will also have a picture. You're going to have to tell me what the baby's position is and where you're going to get the fetal heartbeat. Okay. So we'll start with this, and I'll repeat this. Okay. So what they do here is when they want to determine the baby's position, right? What they're doing is they are, if the baby is going to be vertex head first, the landmark for that baby is the back of the baby's head, the occipital area. Okay. If the baby is breached, then we'll talk about the sacrum is the landmark. Okay, the sacrum is the landmark. We're not going to get into these other. Not going to get into that. We have sacrum. This is the shoulder. So really, it's the occiput we care about and the sacrum we care about as the the landmarks that you're feeling for. So if you feel the sacrum, you know the baby's breached. If you feel the baby's head, then you know the baby is not breached. Okay. So what we're going to do is look at where we're feeling the baby's head if the baby's coming out vertex head first. Okay. And say we're going to look at the mom's abdomen. Okay. So we're looking at the mom's abdomen, not like looking at you and saying that's your right side. We're going to be looking at it pretending you're pregnant, okay? So this is my right side, and this is my left side of my pelvis, okay? So right, left, okay? So what we're going to do is say, okay, this baby here, okay. So if I say to you that the baby's occiput is facing, the back of the baby's head is facing my right side, right? So what you would do is you write down right occiput, okay? And if the baby is anterior or posterior, meaning there's a head, the back of the baby's head facing the mother's front, or is the back of the baby's head facing the mother's back? So right off the bat it would be, first of all, it's the right side on the mom, you're feeling it. You're feeling the occiput because the baby's not breached. And where is that occiput facing? The mother's back or the mother's front? If it's facing, the back of the baby's head facing the mother's back, it's considered posterior. Okay? If the back of the baby's head is facing more to the front, it's anterior. If the baby's head is just straight, not going back or forth, it's considered transverse. If the baby is a breech baby, the sacrum is the landmark we're looking for, okay? So again, the mother's pelvis, which side is that sacrum facing on the mom's pelvis, okay? So if the sacrum is facing the mother's left side, you would say left. Then the landmark is sacrum, so left sacrum, okay? And is the sacrum facing the mother's front of her body or the back of her body? So if the baby's sacrum is facing the front, it's considered anterior. If the baby's sacrum is facing more to the back of the mother, it's posterior. Okay? And I have other slides that I'll put on after you have a break, so you can see what I'm talking about a little bit better. Okay. The presentation, okay, again, you can see here, anterior position of the baby, okay? So the baby's head is facing more to the front of the mother's pelvis. Trying to bring this picture. You see where the occiput is? So that's facing more to the front. And then this baby here, see how opposite they are? This baby here is facing the occiput is facing the mother's tailbone right here. So the back of the baby's head is the landmark, and it's facing the back of the mom's spine, so that's posterior. Okay? And here's another pictures of this. Okay? This baby, this is the mother's pelvis, right? And this side of the pelvis is the right side. This side of the pelvis is the left side. Which side is the occiput facing?
Left side.
Which one?
Left side.
Anybody? Okay, so this is the right side of the mom's pelvis.
The left side.
This is the left side of the mom's pelvis.
It's facing the left
Where's
side.
the back of the baby's head facing?
Left.
Okay. Okay, so then we know left side. And then we also know the middle, that is occiput because the baby is coming out this way. Okay? And the baby's head, I have to say with this picture, it looks almost like a transverse, meaning, oh, I don't really see the nose. So let's say this baby is transverse, meaning the head isn't like this one all the way to the back. Okay? And the head over here is all the way to the front. See how that is? The occiput is to the front of the mom. And this baby's head, the occiput is all the way to the back of the mom. This baby's head is sort of right in the middle. So I'm going to say that this baby is a transverse, meaning it's not right, not front or back. So this baby is left occiput transverse, and you would put LOT. This baby here, the back of the baby's head is facing more to the mother's left pelvis, more. And this
It is.
baby is left occiput.
No, you could see the ear.
Okay, the back of the baby's head is facing the back. Okay. This is, what was that?
Will they stay in that position until?
Yeah, this is usually, when they're checking this, is usually when the woman is in labor. Yeah. Part of the movements of labor, this is how the baby progresses, okay? First you have engagements, you have to memorize this for the test, okay? First you have engagements, so the baby's at the level of the ischial spine, okay? And then you have descent, the baby starts to go below the ischial spine, okay? Then you have flexion, the baby's head starts to flex a little bit, you can see here, to be able to get out. Then there's an internal rotation the baby's head will do. And then the baby will have like a little bit of an extension here. See here, the baby's head's extending out. Usually the baby comes out facing the floor, okay? The head's usually facing down, and when it starts to come out, and then you have external rotation, where the baby will come out and start to turn around a little bit, okay? So that is all the things the baby has to do. And this is usually in the second stage of labor, which I'll talk about too. The second stage of labor, you'll see that the woman's pushing in the second stage of labor, and all of this is happening while she's pushing for the baby to come out. The power, okay, uterine contractions are the primary stimulus, this is the power. Okay, the intra-abdominal pressure from the mother pushing and bearing down. The contractions are not voluntary. She can't say, okay, I'm going to have contraction right now. Not going to happen. It's involuntary. It's a muscle, it's a muscle. So she can't really control when she's going to have a contraction, okay, or stop the contractions. So what will happen is this power of the uterus will cause the cervix to thin out or face and dilate. And then the other thing, before I give you a break, 3 parameters that we are looking for when we're talking about contractions, okay? So we are talking about how frequent are the contractions, okay? And there is like a printed paper with lines on it.
Oh my god.
That I'll bring to my lab. Did you have something in your lab?
Yes.
Okay, I'll bring it to my lab. It's a sheet of paper that has, little lines on it, and it's like, they're equal to 10 seconds apiece, little lines. And that's a graph where when a woman's in labor, it will graph her contractions, okay, when she's actually in labor. And, what we'll see here is we're looking to see, the three different things that we're looking for is how frequent are her contractions, okay? The frequency, and this is also on that quiz, the first quiz, that we're gonna have next week.
Oh.
Frequency of contractions is from the beginning of the contraction. This is a contraction, so it's a contraction. So frequency is from the beginning of the contraction to the beginning of the next contraction. Okay? And again, I'll bring a sheet in, you'll see what I'm talking about a little bit better. So frequency is the beginning of contraction to the beginning of the next contraction, and it's usually in minutes. So you could say, again, I have to show you the graph, 2 to 3 minutes apart, or they're 5 minutes apart. The way you count it is going from the first contraction to the next contraction to the next contraction is the frequency. The duration of the contraction is how long is that contraction lasting, all right? The beginning to the end of one contraction is duration. And usually you'll do a few of these, beginning of this contraction to the end of this contraction, and you can say that the duration, meaning how long is that contraction lasting, if you can say, you know, maybe 30 seconds to 45 seconds. It's usually in seconds, the duration. Okay. And then the intensity. The intensity is where the peak, right here, the acme or the peak of the contraction is, the highest point of the contraction is the intensity, and it's measured in millimeters of mercury. Okay. So this would be what they consider a moderate contraction. So we're looking at this scale here. 0 is no contraction. 25 is considered very mild contraction. 50 is about moderate, and also this line goes up to 100, believe it or not, on the sheet. If a woman starts going to about like 75 to 100, it's considered strong, a strong contraction. So when they say the intensity, you would say, you know, if it was here, it's a moderate contraction. If it was here, it's really like no contraction going on here, or very little. So mild, and if it's up above the 50, it's considered strong. And then, okay, and then physiological response to labor. The fetal heart rate will accelerate, okay? It might decrease a little bit, and there's also a decrease in circulation and perfusion when the woman's contracting. So at the peak of a woman's contraction, what happens is the baby is not getting as well oxygenated, okay? So when it peaks, there's a decrease in circulation to the baby and perfusion to the baby. So the baby's not getting oxygenated at the peak of the contraction, okay? But then when the contraction's over, the baby will get oxygenated again. Okay, there's an increase in arterial carbon dioxide pressure. There's a decrease in fetal breathing movements, because in utero they are able to breathe, you know, show movements of breathing. And there's a decrease in fetal oxygen pressure, okay, decrease in partial pressure of the oxygen. Okay, and then we have the mom's physiological response. Okay. Her heart rate might increase because she's in pain, okay, all right. White blood cell count, it's increased in labor, and it's usually increased the day after. It can go up to like 10 to 12,000 WBCs. Even higher, and they believe it's from the stress of labor, that she has an elevation in her white blood cell count. Her respiratory rate and oxygen consumption is increased. Her gastric motility and food absorption is decreased. Okay. Her temperature, if she's not really eating or drinking anything, she'll have an IV, but there's a possibility she gets a little bit of, she could have a slight, but very low fever. Let's say 98.6 is normal, she might have 99, but it's really from dehydration. Okay. And then muscle aches and cramps, and her blood glucose level, if it's normal to begin with, it should remain normal. If a person has diabetes, again, it might come a little bit low, but they usually come off glucose. So, all right, so let's take our break. Oh wait, oh, it's one left. Hold on, baby, we're not taking a break from the finish this slide. Okay. Psychological response. Factors influencing a positive birth experience. Clear information on the procedure, okay, just like anything. If you don't know, it's very frustrating. I'm in the doctoral program. I just had a meeting with 2 other people in my class. We were totally confused because we don't have outlines. So if you don't have outlines, you're confused, okay? So you have to clarify that what you're going to do, you tell the patient what you're going to do, why you're doing it. Preparation for childbirth experience, you do ask if they have gone. Believe it or not, a couple of people I've met in my life never had a baby before. Oh, I don't want to go to childbirth class. I'm like, oh, okay. I was thinking something you learn from. You learn a lot of this stuff from. Okay. Support, of course, whoever you have there supporting you. Sense of mastery of self-confidence, trust in the staff caring for her, a positive reaction to the pregnancy, and personal control. And this is one of those bouncing balls I was telling my students about the other day. That they can use, sometimes, I'll tell the rest of the class, probably years and most have heard it already. I told us in my lab, the first day we were in labor and delivery at Valley Hospital, it was really funny. It was a group of traditional students, like 20-year-olds, 21-year-olds, whatever. And this guy is out in the hall with his video camera, videotaping, I don't know, whatever he was doing. And he sees me and he goes, oh, are those nursing students? I'm like, yes. And he says, do they want to come in and watch my wife in labor? And I said, well, I guess so, if it's okay with your wife. He goes, yeah, come on in, right? We open the door, and the wife is bouncing on this ball, bare ass naked. Naked. And she's bouncing up and down, and the husband's video cameraing, taking this. Now, I can't, am I watching?
Some kinky
And the students were stunned. The guys, girls, bouncing. And the students looked like they were going to have a heart attack. First day on the floor. Fraternity, right? It was fun. They have a red bouncing ball at that. They do usually, I know. So anyway, have you seen this is the monitoring? You can't listen to that great, but this is like the monitoring. Okay, so take a break now. You want 20 minutes or 15 minutes?
I'll take 20.